This is our rescheduled Dream Week event. So we're really excited about having a conversation with experts in public health, experts in science, to really talk about how we can bridge and build greater equity in our community through science and through conversations like this. So with us today, we have Dr. Cherise Rohr-Allegrini. She is the Chief Executive Officer for the San Antonio AIDS Foundation. Also worked as a scientist by trade early in her career, and then also transitioned into epidemiology and public health. So we're really excited that Dr. Rohr-Allegrini is here with us. We have Corin Reyes, who's a registered nurse. She is the Director of Health Equity for the YWCA and runs their public health programs. So we're very excited that Corin has joined us. Dr. Adelita Cantu, and she's also a registered nurse. She's Associate Professor and Public Health Nurse at UT Health San Antonio. And then Dr. Shelley Cole with Texas Biomed. She's a professor and the Population Health Program co-lead. So we're really excited that they've joined us today. We are recording this session so that we can also share it with the entire Texas Biomed staff and with all of our friends out on social media at some point. So just warning you guys ahead of time that we are recording. And with that, I'm going to actually turn it over to Dr. Rohr-Allegrini, and she will actually MC the event.
Thank you so much. I'm so excited to be here as a former scientist and now public health person. It's wonderful to be with these incredible women with great backgrounds, and so I'm hoping they're going to share a lot with us all today. I'm going to start with Dr. Shelley Cole, who's a basic scientist, and she can talk a little bit about the research that she does.
Okay, thank you very much, and thanks to the organizers for inviting me to be part of this panel and sit here with these leaders in public health in San Antonio. I am a basic scientist. My research involves studying inherited risk factors for heart disease, obesity, and diabetes, and mainly populations that are affected by those diseases, and those tend to be minority populations and underserved populations. And when I say underserved, they're not only underserved as far as medical resources, but they're also rarely included in studies of disease, trying to identify prevalence or risk factors for disease. I believe I'm here to talk about the Strong Heart Study today and my role in that. The Strong Heart Study is an ongoing longitudinal study of heart disease, the risk factors for heart disease in American Indians. The Strong Heart Study began in 1988, and at that time it was really felt, without any evidence, no data, it was just felt that heart disease, rates of heart disease were low in American Indians. So the NIH got together with some investigators who wanted to partner with American Indian communities and figure out what the rates really were, and also identify risk factors for heart disease. And of course, lo and behold, they found that heart disease rates were actually very high in American Indians. They have some of the highest rates of any population group in the U.S. They also went on to identify type 2 diabetes as a major risk factor for heart disease. And that wasn't really known before. They working with some other studies and other population groups, identified that as a major risk factor. So it's very important when we talk about how to get science to communities. We understand that many times communities have no idea what science they need. They have no idea what it is that really is occurring at high rates in their communities. In the process of partnering with the American Indians, the Strong Heart Study was actually a pioneer. I was not involved in the beginning of the study. I got involved in about the year 2000. But they were some of the first to partner with American Indian communities, talk to American Indian communities about what they needed, and they continue to do that today. Each of the 3 field centers in Arizona, North and South Dakota, and Oklahoma partner with the American Indian tribes. They talk to them, they disseminate information on a regular, monthly, sometimes more than
Well, good afternoon. Thank you very much. Good afternoon, everyone, and I'm very honored to be here today. So I am a professor, an associate professor at the School of Nursing at the Health Science Center, and I teach population health to undergraduate nursing students in their last semester before they graduate. And I think one of the things that we focus on during that course, which we're just finishing up for the spring semester, is helping students understand the factors in the communities where people come from, where their patients in the hospital come from, and understanding that where that person lives, works, and plays often is more impactful to their health that they see in the hospital than giving them a medication or any kind of treatment. And so if we can get our nursing staff or nursing workforce to understand that not only do you have to be competent in terms of giving medications, treatments in the hospital, but competent enough to know that the community in which they come from can also play a part in those health outcomes. For instance, many communities, underserved communities, are where you see the patients that get into the hospital with diabetes that's uncontrolled. And the nurse may fix them for that acute period, but then if you send them right back into a community where they're food insecure, they don't know where their next meals are coming from, or only one HEB and very limited fruits and vegetable capability, you're going to end up seeing the patient back in the hospital for uncontrolled diabetes. So I'm working towards giving students in our future nursing workforce the link between what they're seeing in the hospital and how we also need to understand our community factors, because they play such an important part in health outcomes. And that's what we call the social determinants of health. There are things in our society and the way our society is structured, the infrastructure, that has a negative impact on health. So that's where we make that connection, and a lot of it goes to research too, because what we know about risk factors, and we can translate that into the community to help people understand what they need to do, where they live, work, and play, to promote their health. And population-wise, what we can do to promote the health of the neighborhood, which is something where the YWCA comes in and other facilities.
Thank you. So this order was intentional. We have our basic scientists, our applied researcher, and then we have our representative of the YWCA. So what I really like to hear a little bit is about. We're too close together. I would really like to hear from Corin to talk about your role as Director of Health Equity in a community-based organization like the YWCA and how that applies. Take the work from our other two scientists into the community.
For sure. I was wondering if this order was intentional, because I was like, okay, so, once the data comes and then the nursing staff can look at that data and say, okay, this is how I handle patients, we're kind of the downstream end of that. So we are the resources that be available to patients identified by the staff. We provide anything from, do you need food, do you need a ride, do you just need funds for a mammogram maybe, or so pretty much anything that you can imagine as a resource that somebody would need, we offer those resources to them. So I lead a team of community health workers. There's about 20 of us, and we do a variety of different things. Everything from food pantry delivery to senior fitness, mammograms, and then most recently vaccine equity. So not just the COVID vaccine though, but all vaccines. So yeah, that's that was interesting.
Very intentional. Thank you. So now I'm going to answer just a couple specific questions for you all. Dr. Cool, if you want to talk, you talked a little bit about your Strong Heart program. How does access to resources, in particular the population you're working with, impact somebody's health, and how do you overcome that?
Yeah, part of the Strong Heart study is conducted in North and South Dakota in some of the poorest counties in the U.S. They're rural. People don't have access really to anything. clinics with MRIs are a 4-hour drive away. So it's really, really difficult for people like me, you know, who have resources. It's really hard to understand what that's like to maintain your health and get the information you need and the resources you need to maintain your health. There's a lot of support for elders. There's a lot of respect for elders in the community, but that still doesn't counteract the fact that the resources just aren't there. So we have field staff who do wellness checks on individuals. They travel, they will drive 2 miles, pick up a couple of participants, bring them back to the clinic. It's a whole day affair. And they're maybe part of a study, an ongoing study, where they do get, in a sense, some free health care because they're given a clinic exam for the study. And many times that's where they identify things. They'll identify blockage in the heart, or high blood pressure, or something, because they haven't been to the doctor in so long. They're just not aware of those things. So where you live, the resources, the history, differences in culture, and how one perceives healthcare and medicine are really, really important. And we need to consider those when we come up with programs as these ladies do, and how to reach people and give them the resources they need.
Thank you. My next question is going to tie into that. I'm going to start with Corin to answer this, and then I'm going to come back to you, Dr. Cantu. So it's not surprising that in rural North Dakota, the access to those resources, driving many miles, is a problem. But in San Antonio, it's a big city with 2 million people, and many of us think we all have access to those resources. In your work, Corin, how have you found that there's barriers to access to care?
I definitely think that when we look at urban areas, we think that the access is easy. Even if you don't have a car, you have a bus, but it's really not that easy because can you even afford to get on the bus? Because a lot of times that's what we find. And if you don't have a stable home to go back to, that also makes transporting yourself very difficult, as well as maintaining communication with other people if you're in one house one day and couch surfing to another house the other day. In addition to that, it's odd to think that even in a city like San Antonio that there's lack of internet access or broadband access for certain populations, but we have a huge internet divide, and I think we all really felt that during the pandemic and noticed that some kids couldn't go home with a tablet because there was no internet there for them. And we've done a lot to kind of shrink that gap by offering hotspots at different locations, but the gap still exists. And then when we think about access to information, we also need to look like not just can I access it, but do I understand it? And that's kind of where we come in our work, and taking that information and turning it into something that people can actually read, understand, comprehend, and relate to. Like, am I going to just put out a flyer with a blonde-haired, blue-eyed woman saying, please come do this? Or do I need to make sure that the people in that flyer look like me in order for me to understand it? So that's my answer.
And now I'm going to turn to Dr. Cantu to follow up on that. In your work with your training nurses, how do you train nurses to take that information out into the field?
Well, one of the things that we do is really focus on the resources that are available in San Antonio so that the students understand resources like the YWCA and what they do, so when they are practicing in the hospital that they can help people bridge that gap into the community. So nurses, for I guess the last 3 decades, have been considered the most trusted profession. And because of that, I think when nurses discharge a patient from the hospital, that they have that connection, and that connection can help bridge those resource gaps if they are in the community. So one, in our course, we do give them a sense of all the different resources that are out there. But we also try to give students a sense that other people have different perceptions of health, and how I can achieve that health knowing what my perspectives are. So we put students in a lot of situations, simulated experiences. We have a poverty simulation where students are in the simulation, and we poverty, that's what's simulated. And so then we debrief, which is really, really important after the experience, because the students are doing it for a couple of hours, but their stress levels start going up. And so we talk about physically what happens to our body, the releasing of cortisol, and that was just for a couple of hours, and how poverty has that cumulative effect of stress, and then it has a physical effect as well. So we're trying to help the students before they go into practice to understand the situation so that they can be more culturally sensitive and culturally competent when they go in. I was just talking before, one of the activities I have them go to a couple of places on the bus, a couple of resources. I don't tell them the address, I don't tell them how to get there, I just say you need to get there on the bus and you need to come back to this spot. And again, to understand lack of access, and access just isn't transportation, but students start understanding if I didn't have that phone with the VIA app to tell you exactly how to plan your trip, that they couldn't have done it. So therefore they understand why people that are low income or live in poverty prioritize their phone, because it helps give them access. Not transportation, but just access to a lot of different things. So those are some of the ways that we try to bridge that gap from their preparation educationally to going to open to the community.
Thank you. I also want to remind you all that feel free to jump in before I ask any question you want to respond to what any of your fellow panelists say. The next question I want to is tying it all together. I'm actually going to bring it back to Corin, and then we're going to go back down the line. You've all spoken of this a little bit. We've talked a lot in the last few years about social determinants of health, and that means different things to different people. So I'm actually going to ask each of you to talk about what that means to you in terms of health equity and the work that you do.
In my opinion, social determinants of health and health equity are two different conversations that merge at points. So when we're talking social determinants of health, we're talking, is my environment safe? Do I have lead pipes? And also, is my household a safe place for me to be at because the people there are safe? And we're talking about all those different things that make us a healthy person, from our food to our water to our nutrition to our education as well, education being a key piece of that. But then when we talk about health equity, we're talking, in addition, when I do go get health care, am I getting treated the same as everybody else? And are the treatments that are available to me culturally appropriate? For instance, am I going to treat a black male that's coming in diagnosed with prostate cancer the exact same way I'm going to treat a white male? And we know that that's not the case, because black men often end up with stage 4 prostate cancer because they weren't treated as aggressively as their white counterparts. So that's kind of where the health equity piece comes in, and I think that you can't have equity without talking about social determinants of health, but they are two different conversations.
And I'll just use a metaphor for social determinants of health is upstream and downstream. So if an example of a downstream issue would be a child coming in with uncontrolled asthma or asthma exacerbation, and that's a downstream issue. And upstream, you would go and see that the city rezoned their neighborhood to allow a plant to come in, a factory to come in, and so they do emit certain chemicals that then exaggerate the asthma. So the rezoning of that to allow that plant to come in is upstream. So it's just the plant, but the downstream effect of it is more children with, in that neighborhood with asthma that's not controlled. So I use that metaphor for upstream, downstream to understand the social determinants of health. And that there are structures within our society that we've all agreed on as a society that do have a negative impact, such as our healthcare system. Right now, we have decided that it's health insurance that is our way in, and that means there are going to be some people that don't have health insurance, and it's going to have limited access, or their access when it's more acute. So that's that upstream to downstream issue. I use that metaphor a lot to try to help students understand that what they're seeing in the hospital is more downstream to really have an impact so that patient doesn't come back. We need to go further upstream.
Dr. Cole, especially as a scientist working in an area where actually social determinants of health are a big factor, how do you interpret it? How do you use that in your work?
Yeah, it's hard for me as an investigator to separate cultural determinants from social determinants of health. Culturally, as we all know, American Indians have been pretty much abused by the federal government as well as scientists in the past. And so one of our biggest hurdles in trying to partner with tribal communities and work with them on collecting the type of data they need is gaining their trust. Gaining their trust that we're not going to come in as scientists, collect a bunch of data, leave, publish our papers, and get promotions and never return to the community. So the Strong Heart Study attempts this on many, many levels, and I can't take credit for what has been done on the Strong Heart Study in this regard. Wonderful team members, hire community members as research staff. They go back to the community, as I said many times, to disseminate results, identify what's important. We're kept honest in our work because we have to get approval for what we want to publish. We also have to respect their culture and the cultural differences. When they give us samples, that's actually giving of themselves. We are holding part of them in our hands when we work with their samples. And so we have to respect that. And there are, I learn every single day something new. And something I didn't understand, and it usually takes me off guard. But I think one of the things that I've learned, well, there are two things. One is that the tribes are tired of hearing that they're obese and they eat the wrong foods, right? They're just tired of hearing that because nobody's helped them, right? So what we're trying to do is highlight the strengths of their culture and try to work with those when we talk about social determinants of health. And one of the things that I've learned just a few years ago that sticks with me is they have this saying about thinking 7 generations ahead. So they make decisions based on how it's going to impact 7 generations ahead. And that's so different than Western culture and how we think. And I really appreciate that, and I try to remember that when we're at the steering committee level discussing issues and how are we going to bring this to the tribes and what should we do. I try to keep that in mind because I think that really helps frame it in a way that will help us reach out to them better and listen to them.
Thank you, and I'm so glad you brought up a number of points that maybe reminded me of when I was in public health school 30 years ago. One of the things they really warned us about was so many communities are used to scientists coming in, taking their data, and then they publish something, but it doesn't mean anything for the people that are there, and remembering that you need to go back to the community and work with the community. It sounds like that's a significant part of the Strong Heart Study. So thank you. Okay, so I'm going to ask, all of you, I'm going to ask a little bit the same question, but a little bit different way. I'll start with Dr. Cantu. As a public health professional, if you're asked, if you wanted to ask a scientist how to share their work, I kind of see you as the translator. How would you tell a scientist to communicate their work to the community?
Great question. And in all my years as a public health nurse, my touchstone has always been, how can I explain it to my mother? Does my mother understand it? And that's what I would tell scientists. Think about your mother, or think about your grandparents. How do you say it in such a way? And not in any way a perception that people have less knowledge than you do. But people understand it at their perspective, based on their culture, based on their family, etc. And so that's always been my touchstone, is, okay, am I explaining it in that way? And then also, I want to have the individual tell me if I've done it correctly. So I always end with, and I would say for scientists, always end, now what questions do you have for me? So that I can understand that they've understood me. Or maybe I said it completely wrong, and this is, I'm hearing them and say, okay, I need to start, it's me found that to be helpful no matter what situation I'm in with community members.
I'm going to turn to Corin now and ask more or less the same question. Maybe if you can use some of your experiences. You talked about when you're working vaccine equity. How do you take the information about vaccines, for example, or you can use another example, and take that to the community when they have questions?
Yeah, for sure. A lot of our information comes down from the CDC and from NIH, so it's definitely not necessarily palatable to the general community. So I have the honor and privilege of working with a group of 20 young women who are trained to become community health workers that are also kind of in that 19 to 25 age range, and they turn all this information into TikToks. And it sounds like crazy, but it's so relatable, and it really makes people like happy to see somebody dancing to a COVID-19 vaccine informational. So that's how we translate it for different generations and our work. So I just really thought it was really neat that you have community members that you guys have trained to work in the field, and like, I don't know, I just think that's, yeah, it makes a big difference for us, like our workers are community members too, and how much people want to talk to us, relate to us, tell us information, and then also like having somebody who's basically like an influencer going back into the community. Essentially, so I just thought that was really cool. So I can't take credit.
I just wanted to say the community health workers that Corin has been talking about science, because that is an evidence-based model of how we can translate things into the community, is using those influencers in the community. So it was through science that we've understood that community health workers can be so positive. And I think that it's really great to see the growth of that.
Absolutely. And I'm actually really excited because working in the world of HIV, I want to hook up with y'all with your TikToks. There's some good HIV videos for TikTok. And Dr. Cole, you've talked about this a lot already, but if you have anything to add in terms of as a scientist, how do you talk to your fellow scientists to get them to communicate? I think with your program, there's a lot of years of experience in doing it.
Yeah, it's a bit tough at first if someone has never been involved in a project that's community-based. Scientists, we're trained to use jargon, we're trained to show off to our peers because our publications are peer-reviewed, our grants are peer-reviewed. We want to show we know the latest and greatest in the field, so we're using all the buzzwords. And sometimes when we ask people to write a lay summary of their research to present to the Tribal Health Board, it's difficult. They just don't know how to do it. It's hard for them to step out of that role. We don't get any training to talk to communities. We don't get any training for that at all. And we're not rewarded for doing it, right? So that part is really, really tough. I do think it was early on, when the study first started, the principal investigators insisted on hiring community members to do the exams, and they were told by other epidemiologists that would never work. They needed people clinically trained. They needed clinically trained technicians to do it, and they proved them wrong. And it's also providing capacity building for the community, training people to become health aides and work in the health field. A lot of American Indians have gotten their degrees, their PhDs on research projects they conducted in the community using strong heart study data. So one way to communicate with the communities and the tribal communities is to let them know that we're there and there are people they can talk to. And as we train community members, we learn a lot more about how to be better communicators ourselves.
So you just made me think that Texas Biomed should also hook up with the YWCA. This is a great training program to help teach scientists how to communicate. But I do need to shout out to Texas Biomed and MSCL. I've had an amazing experience with Texas Biomed scientists communicating to the public in a way that's very relatable. So either y'all just got lucky or you're doing something well. All right, so I just wanted to give you all one more chance to add anything before we open it up to questions. No? Okay. We can go ahead and take questions from our group. Don't be shy.
I have a question, of course.
I have a question. I feel like we hear a lot in the current climate in Texas these days about whether when you're sensitive to culture, race, diversity, inclusion, you know, there's a lot of politics going on around that right now, and how, especially teaching our younger persons how to be culturally sensitive. How are you all faring amid that? I always say San Antonio is an oasis oftentimes from some of this, but Texas does not currently have the best reputation when it comes to systemic teaching of cultural sensitivity. So talk a little bit about that, please.
I agree, San Antonio is an oasis. We are very lucky in that respect. For us, it's also still been a difficult conversation. I think people are still wanting to. We spent a lot of years in this country saying very awful things to each other and doing very racist things in our country. And then when we kind of moved past that, we just said, okay, we're not going to talk about race anymore. We're just going to all be one the same. But we have to get over that hump and say, okay, it's okay to talk about race, and we honor everybody's race, and our differences are great. So we're needing to get to that point, and we still haven't fully got there. So even within the community and having to have conversations about, okay, we have to make flyers that include everybody, it's always a touchy conversation because people feel slightly offended that, oh, my flyer wasn't culturally competent, and they have no idea. So it's still a touchy conversation, but we're getting there. So.
It's a great question because that's been on our mind definitely in the last year as an instructor and faculty. And so a couple of things. One, in terms of talking with students relative to this, in some way research makes it easy because you can point to the evidence of what racial discrimination or discrimination does physically, and then that translates to health outcomes. So there's that hard science component to that you can't necessarily say, oh no, that's not true, because the evidence is there. So that's one thing. The other thing is that I'm still learning myself. So just this past semester, I had students touring Haven for Hope, the campus downtown for people that are experiencing homelessness. And as our tour guide went on, and he always kept saying people who experienced homelessness. Mm-hmm. And I made a note of that because if you just say homeless people, you're labeling. And I'm starting to understand that. So we had a conversation with the students and learning that, because I just learned it myself, and I always try to correct myself with it, people who have experienced homelessness. So going back a little bit to what you said in science is not having the communication skills. Doctors and nurses don't either. We don't necessarily put that into the curriculum, so we have to look for those opportunities to stop and say, well, wait a minute, maybe the way we're saying something is perpetuating those stereotypes, perpetuating that discrimination. So it's a learning experience, and we have to begin with ourselves. Mm-hmm. And just that little thing about people who experience homelessness. Oh, yeah, okay, now I understand.
My 9-year-old schooled me on that the other day, and I felt very taken aback. She said, "No, Mom, it's people who experience homelessness." I was like, "Okay."
She would. And that's a 9-year-old, so that's great. So they are having the conversations. Definitely.
Yes.
Just briefly, being culturally aware sometimes can cause time delays in getting research done that don't fit with the expectations of the institute you're working for. So we run into that a lot, where a young investigator it's not that they're not culturally sensitive, they just don't have the time to wait an extra 3 months to get tribal approval of a manuscript, or take the risk that they write a manuscript, they do the work, they write the manuscript, and in the end the tribes won't approve it because they don't like how it's going to be presented or how it's going to present them to the world. And so that's, I think, to get young people involved in the science, that's probably the biggest hurdle when it comes to being culturally aware.
That's actually a really, really good point. And I know we mostly in Texas Biomed here, but I think for institutes everywhere need to think about that and recognize that. And that's really difficult to change that institutional culture. Even in the work that I do with HIV, we worked really hard to change our language from people who are HIV positive or being HIV positive. We talk about people living with HIV, similar to experiencing homelessness. Yet all of our documents from CDC, from NIH, all the paperwork says HIV positive. People who are HIV positive. So it's identifying them by their infection rather than as a person who happens to have that infection. And we're working on it to change our language, but changing the institutional language is really hard. All right, so any other questions? I'll walk around.
Could you talk more about some of your experiences of what you found has worked with making a connection with the community? So I've heard listening, TikTok, but I would just love to hear more experiences or more examples that we could take away, either as communicators or scientists or members of the public. What have been some things that have worked, and maybe what's not worked, where you thought you were doing something that was going to connect or be positive, and then it actually fell on its face?
Well, I'll start with that. Great question. And I would say presence, being physically present and physically present, and then being responsive. So there are many agencies that I've worked with over the years, and not only do they see me, but when they send me an email, I'll respond to that email. So that's what I would say: presence and the responsiveness, and that builds up that trust over time.
And I concur with Dr. Cantu. Like, one thing that I learned a lot from our partners at UT Health is just building a conversation with people. Like, we're not going to say, okay, come in, let's talk about health. Come in, let's make tamales together. You know, and that's how we start a conversation. We build a relationship first. So what hasn't worked, anytime we tell somebody what they need. So we have come up with this really good program, so we're like, these are going to work, and we take them out to the community, and they're like, no. And it's not because they're not good programs, it's because we didn't ask first. So just building that trust that way.
Yeah, and I would just echo showing up. Our field staff go to festivals, powwows, concerts, whatever, have a booth. They tell me sometimes nobody shows up at the booth, but later they hear, oh yeah, Strong Heart Study had a booth at that event. So just be present.
So important, and being visible in the community is the part of building that trust. It has to start there.
So in terms of, you talked a lot about building trust, but what can we as community members, just general community members, do? What can we as community members do to help public health professionals communicate to us even better? Like, how can we listen as general community members more effectively? And where that's coming from, where that question's coming from is, I know the nursing profession in particular, they're exhausted, right? The nurses are tired right now. Our entire medical professional community is tired. The scientists are tired. So, like, everybody's tired. How can we in the community be better, I guess, community citizens to those of you who are trying to talk to us?
Yeah, you know what? That's a tough question. From my perspective, I really don't know that there's anything that community members need to change. Like, we've set the precedent as a medical profession that has built a system of distrust, and we just gotta wait it out. And that's long and short of it. I always tell my daughter when she's very mad at me about what seems like nothing, she's a preteen, that I am not your
lives next to me, but people like seniors that go to a senior center, caring for one another, knowing what might be going on, or if something looks out of the ordinary, say something. One of the other ways is to think about your city representation and making a contact with your city council, because they're a great resource as well. And that's what they do, is they have constituent services there. So if I hear of someone who may be having trouble in my neighborhood, maybe call city council and say, hey, is there anything that can be done for this individual or for an individual that has experienced this situation? So I think, yeah, in whatever way and capacity is being that neighbor.
And I guess just as a basic scientist, I would say, remind people science isn't going to always give you the answer you want to hear. And sometimes science doesn't have an answer, and that's because we just don't have the data yet to give you an answer. And that doesn't mean that you should discount all science. It's just we don't have the data, and we're not going to go on hunches.
That's an excellent point.
Yeah, particularly during this time of the pandemic, and they don't have all the answers, and they didn't in the first couple of that first year, and now it gets better, but people sometimes don't understand that science learns as well.
Absolutely, and I want to add to that too is to speak up and ask questions and validate your information. So I know it's so hard for community members to find information they can trust because there's so much out there. But before you share information, to do some investigation, find the few trusted resources you have to make sure it's accurate information before you share it. And then you become a trusted resource for your friends and family. Even if you're not a healthcare professional, you're not a scientist, if you're giving out good information, people start to rely on you. We know that from, especially in the vaccine world, the people that we communicate with, it's the grandmothers, it's the moms, and they don't, the person down the street isn't going to listen to the doctor that tells them this is right, they're going to listen to the mom who just went through it. So making sure, it's our job to make